Hi, this is Dr. Tom Rogers coming to you with a weekly podcast of what I call the Common Sense MD. Today I have a special guest, good friend for years and patient as a matter of fact, Dr. Backus. He's an emergency room physician for many years, but the reason I really wanted him to come on to my show, we were talking the other night, we were at a meeting together, and he's gotten into addiction medicine, and that's his main gig right now. So great to have you. Thank you. I've been wanting to get you on this for a while anyway. I'm really fascinated by addictions. Addiction medicine is very on the rise and it's misunderstood. And I want to, you're such a great guy. You're a great doctor, and I'm really happy to be able to send you patients now that I know you're doing this. And you've got quite a big operation. So first of all, tell me how you got into ER medicine and then addiction medicine.
Okay, sure. Thank you for having me. This is great, and likewise, kudos to you as well. And I think highly of you and all you do in functional medicine. It's changing the world, in my opinion. So hopefully we'll hit it from the addiction side now. So as far as emergency medicine, when I was 11, I realized at that point that I had a passion for people, and that I came from kind of a rougher family, and I don't know, for some reason I just thought that, hey, I want to be a physician someday. Awesome. And so from that age on, as my pursuit was that. So emergency medicine was kind of a twofold type of a process. So I started out in general surgery. Was there 2 years in general surgery, did some research, laparoscopic research, really loved it, but had 2 kids when I was in surgery and realized that my hours were really long. At that time, there was no restrictions. And so I had to make a decision, and I felt like I needed to, just that my cards dealt to me by God were a little different than most. And so I loved surgery, but realized my next passion I'd have to pursue instead for family reasons. And so that was emergency medicine. So I was able to transfer out, found a program, University of Mississippi, that I could get into. And they accepted some of my work, I guess, but then pretty much had to start over on the other. And then got into emergency medicine, loved it, practiced emergency medicine for about 22 years.
Wow.
Yep. And then while I was there, realized that there was a real need, especially in this area, that we were seeing a lot of people, a lot of patients come in that really our staff was complaining a lot about, and you're busy in the ER and you're dealing with a lot of critical issues, and you have folks coming in seeking out pain medications for various reasons and in various ways. I think it can either catch you and pull at your heart, or it can run you the other direction and make you real critical. And we had a lot of critical folks. And so unfortunately, that's the way of addiction medicine, as it's been criticized for a while now because of some of its treatment modalities. But it's becoming less scrutinized, I feel like, as folks like you kind of publicize this, and people are realizing the need and also the legitimacy of it. So anyway, I felt like, hey, this is a great opportunity to help someone who's hurting, because obviously if they're in this position and they're doing these kind of things to get pain medicine, there's something to this. They're losing their families, they're out on the streets, they're losing jobs, they can't hold one down. I mean, they're a mess. I mean, they're losing their lives. There's something to this. And so I had a neighbor at the time who was an internist who said, hey, I think you'd be really good in addiction medicine. And I was like, I don't know, I'm not sure, if I would enjoy that or not, but I really feel like I'm developing a heart for it. And he invited me to come to his office, and I did, and I was hooked. The people are amazing, their hearts are amazing. The ones who are really involved and really truly want help and for their substance use disorder really are great folks, and they struggle, and they just have some dysfunctions that are different than ours, but we all have them, right? We all have dysfunctions, of some sort. So anyway, that's how it started.
That's a great description of how you started out in this, and I can correlate what you said about general surgery. My dad was a general surgeon, and I loved going in and operating with him many years ago, way before I became a doctor, because back then you could do it. But I knew I didn't want to be a general surgeon because of his lifestyle. It was every night.
Yes.
It was a tough one. And then my brother became one. But I tended more towards family practice, primary care, so I like that.
You're perfect for it. Your personality
suited to me better.
Yes.
But I appreciate your history with that, and I can identify with that. But you're right. There's a lot of people out there that hurt. If you've been practicing medicine as long as we have, people have pain, and unfortunately, it kind of got a bad name because back in the early days, I remember in my practice, if I had somebody with back pain, I thought, man, I'm not so sure about this. You can't really see anything wrong. But then when I developed a bad back, and I have a lot of back pain. Anybody that listens to my podcast know I have a pretty crooked spine and degenerative disc disease, and it's bad every day, but not to the point where I really need to do much more except therapy and that kind of thing. But anyway, there's great people out there that have pain, and they get mislabeled and they get kind of shunned, and so have some of the addiction medicine specialists. I mean, you hear about the pill clinics and all this, and it is true that some of them, just come in, write your script, and they're gone. But what I was impressed by with you is the all-encompassing thing that you have with the psychosocial model. It's not just, here's your Suboxone. I was there in the opiate crisis, of course, listening to representatives from Purdue Pharma would come to my office, and that whole thing with OxyContin, and we've talked about that on the shows in the past. But so you're different because you look at everything. Where are these people going to go live? They've lost their families. I mean, I've had a couple partners get addicted to opiates since I've been practicing. I mean, good, smart people who lost everything, not only their practice, but their family. One of them ended up doing some jail time for it. So it's really a terrible thing. And that one doctor I'm thinking about, he told me, because I asked him, he'd been in rehab many times, and why do you keep doing this? And he said, the first time when I was in medical school that we were on the pediatric ward, and the attending doctor said, I want you to taste this cough medicine that these kids have to take. And, of course, it had hydrocodone in it. So he took a taste of it. He told me as soon as he tasted it, he knew he had to have it. That will always stick with me.
Yes.
So talk a little bit about opiates and Suboxone and how you deal with this crisis.
Sure. And that's a great lead-in, man. That's I don't have to say much more after that, because that's exactly how it is. And so that's it. So there actually has been some studies out there showing or asking thousands of patients who struggle with addiction and those who don't, what they felt or experienced when they first tried a pain medication of some sort, whether it was recreationally or it was by prescription. And unfortunately, a lot of people in the day did get addicted from prescriptions, but there's also folks that get addicted from using it recreationally nowadays, of course. And on that study, from that, they found that those that struggle with addiction were exactly like your friend. They felt completely different than other folks who didn't become addicted. They had various ways of explaining it as, I was flying above the ceiling, I was sinking into the floor, I felt like I could take on the world, I had no problems whatsoever, I had tons of energy. These are some comments that they would have, and that's exactly it. It's a brain disease. So, that's kind of what I think. Yep. So it wasn't until the 1700s, with Benjamin Rush, Dr. Benjamin Rush, who was really studying alcohol more at the time, and addiction has been around for a while, obviously. Substance use disorders have been around for a while. Started mostly with alcohol and getting the treatment centers, and then it progressed into, other substances, and really didn't become formal. The Society of Addiction Medicine started was accepted by the American Medical Association in 1990. So it's still pretty new, like emergency medicine, it's pretty new. But with that, they determined, 1700s, that it was a brain disorder. This wasn't just a psychological, social, moral, or a criminal kind of a problem. This was definitely a genetic or a brain disease of some sort. Some of it, I think, epigenetics. It's developed with environmental reasons, family histories, seeing family and that kind of thing, and it sort of changed their genetic makeup, and then they were able to pass it along. So, without getting too scientific with it, that's really been a struggle, and that's the reason is people are prone to this or not.
Yep. Life is not fair, is it?
No, it's not always fair, is it? Yeah, it isn't.
That's what I tell all my patients. They come in, why do I have this? Well, we're going to try to find out, but I'll tell you one thing you better accept. Life is not fair.
Yeah, that's right. And the thing is you can either take it as a victim and say it's not fair and woe is me, or you can tackle it full on, like hopefully we want them to do, and we push them to do. And that's what we do in addiction medicine. And like you said, it's a multifaceted approach that we take. It is not just about writing medications, and we write more than Suboxone. Suboxone's been around and used since early 2000s. It came after methadone when they realized, methadone's been around since the 30s and Hitler, but it was used in addiction early 90s as well, just before, maybe upper 80s. And a lot of people ended up even dying from methadone, believe it or not. So we realized that Suboxone it's a partial agonist, which means it knocks out, it doesn't give you quite the full effect of an opiate. So it's really not quite the same as a pain medication, full-on pain medicine or a full-on agonist, but it will knock that off of the receptors, and there's a ceiling on it. So the great thing about it is those who struggle with addictions, we can feel safe knowing that they take this medicine, should they take it only. It has a ceiling to protect them from overdose, which is obviously a big issue
It's
today.
unbelievable how much with the fentanyl and all this stuff. I mean, it's
terrible.
unbelievably dangerous these days. But when I was thinking about that, you just said Suboxone, and when I used to see a patient that was on Suboxone, I'd kind of think, well, man, but really I've changed my mind about it, because actually with a lot of people, it allows them to be a normal, functioning human being. They couldn't do without it. Then I used to think, well, why are you still on Suboxone? You've been on this stuff for 3 years. You're still on it. I thought the purpose was for them to get you off of that. Are they just keeping you on that to churn up the bill and make money? But really, it's almost a maintenance medication for a lot of that. And
it is. Man, again, another great lead is exactly that. So when I started out, my goal was to get everyone off of everything. And I've been doing this over 15 years now. I've been in addiction medicine for over 15 years. And we've seen a lot of changes. We've seen a lot of regulations come, which were well needed, from some of the issues that you mentioned early on. And people sort of using it just to get people in and out and make money from it, even though the medication in 80% of the population will help them to function and to actually get back to work, care for their families, to be safe, obviously prevent from overdose or jail and that kind of stuff. But yeah, it's one of those medications that I sort of have adopted as a long-term maintenance, because I realized after a few years that people when I'd get them off the medication, they'd go back to the streets. They'd go back and overdose on medications. They'd go other places that weren't doing things in a multifaceted or multidisciplinary kind of way, where we're providing counseling and we're providing peer recovery type specialists or patient resource advocates, getting them resources, teaching them life skills, how to make goals, that kind of stuff. And so I said, I have to think about this a little bit more. I see these folks and they look completely normal when they're taking the medication. They look completely normal. It is not like what people think. They're not flying high. They're not, in some second world or whatever. This is another replacement kind of a drug for, another. No, they're functioning and they're in jobs. And it is people like you and I know as well. It's all walks of life. And so
all walks.
Yeah, all walks. So we use it with other medications as well. It's not just that medication, and we will try to push our patients to, less is best in my mind. I think that's how God created us, is less synthetic things we have in our body. And
I agree.
This is your world. And so we try to push them in, at least to lower doses or off. We look to see where they are in their neurotransmitter position at that time, and are they still going to have cravings? Are they still going to be a risk? And if they're a risk, and we use scales to determine this, then we just kind of get them to the lowest dose that stop that risk. So
I love your approach to this, because it's really, to me, and knowing you and talking to you, it's almost like a mission. It's part of your doing for others, more than yourself. And really, because you could just be an ER doc the rest of your life and come in, punch a clock, treat people in and out, but you really have a heart for this. I mean, you're on a mission to me, and you're doing great things because it's all encompassing. I've seen what you do, and it's not only just here's your prescription. It's let's look at your whole life. Let's work the whole family in with this. You can't do this alone. We're here to help you with the whole process of all the things with psychologists, with nutritionists, with laboratory medicine. I mean, I see a lot of these patients that you have because they have low hormones because of the medicines they have to take.
Exactly. Nutritional deficiencies. And exactly. I completely agree. And another great point, I feel like we had a great example in not to get too crazy religious or spiritual, but in Jesus, that was walking this earth to show us what true love and compassion is. And I think that's what we're supposed to do in life, wherever we are, whatever position we're in. And this is my calling. This is a ministry for me, because I feel like that